edition of the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very safe, and very bright United Arab Emirates. And I'm joined today by some spectacular faculty from around the globe. I'm a consultant medical oncologist, as I mentioned, and I'm joined by many consultant medical oncologists. I'm going to allow them to introduce themselves. I'm going to first allow our international faculty, Peter, to introduce himself. Peter, can you introduce yourself?
Yes, my name is Peter Fasching, and I'm heading the Breast Cancer and Gynecological Oncology Center at the University Hospital Erlangen, which is a comprehensive cancer center and one of the locations of the National Center for Tumor Diseases. And I know most of you, and I love the region. I love coming there. And I have to tell you something. I put in a travel request for September this year. So let's see what happens.
Well, hopefully we'll have you in our part of the world soon. Maha, can you introduce yourself?
Hello, good afternoon. Thank you for having me, Dr. Shaheenah. With you, it's always a pleasure. Good afternoon, Dr. Peter Fasching. It's very nice to have you again, and hopefully we'll see you in person. My name is Dr. Maha. Sindi. I'm a medical oncology consultant with an interest in breast and gynecological malignancy, and I work in Bahrain Oncology Center.
Ozge.
Yes. Hi, everyone. It's pleasure to be in this meeting tonight. It was always fun and full of joy under the moderation of you, Dr. Shaheenah, and also it was pleasure to have Dr. Peter with us again. Last time we met in person, hopefully next time again in person. I'm a consultant medical oncologist. It's my 6th year in Bahrain Oncology Center, which is a national cancer center. Hope everyone joyful meeting.
Sinem.
Hello, everyone. This is Dr. Sinem Akbas from Bahrain Oncology Center as well. And I'm sending my warmest greetings to all of you.
Thank you. And Dr. Tarkan.
I'm Dr. Tarkan. Thank you being again with the team together with the friends. Sorry. I'm a consultant medical oncologist in Bahrain Oncology Center.
Thank you. So let's show the agenda, if the team can put that up. We're today going to be talking about the role of CDK4/6 inhibitors in the early as well as metastatic phase of a disease. And we're going to start off with Peter talking about from advanced to early stage breast cancer, a CDK4/6 inhibitor overview. And after that, I've got cases, and we're going to do boom, 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 and put everyone on the spot and really get what they're going to do in the clinic practically, outside the realms of a clinical trial. So Peter, take it away. Give us your thoughts on CDK4/6 inhibitors in clinical practice.
Okay. So what's keeping? No, that's not the one. Hold on. This is number 4. So there we go. So it's an absolute pleasure, and some of you might have already seen these slides or similar slides, but I'm going to squeeze in some information that you might not have had yet in the context of CDK4/6 inhibitors. And this is basically only the basis, I guess, for Shaheenah's cases. And I think I slowly find out, Shaheenah, why you're having so many cases. You're actually seeing those patients, and these are actual questions from clinical practice that drive us around when you're presenting us these cases. So my presentation is just the basis for our discussion later. And I was asked to give like a fireworks, it's like a all-inclusive package for metastatic and early breast cancer. And most of it is repetition. When we're looking at endocrine resistance, the substance-mediated endocrine resistance or the pathway-mediated endocrine resistance that is primarily overcome by a new treatment, we see at the beginning of the Kaplan-Meier curve. But we see here, this is the comparator that's in the everolimus approval trial. These patients progress without the mTOR inhibition. Adding the mTOR inhibition, we can see we can overcome specifically this resistance in this percentage of patients. But as you can see here, almost every patient will still progress from the disease, and there's new data coming up almost every patient will still die of this disease, regardless of an extending of median overall survival or not. So that's something very important to keep in mind. You know, when we overcome endocrine resistance, what does it do? It improves progression-free survival, sometimes overall survival, and that's something we have to take advantage of for our patients. We now have extensive experience with the palbociclib, with the ribociclib, and with the abemaciclib. All of these trials have provided plenty of information overcoming endocrine resistance. And to make a long story short, don't look at the numbers. Hear my words. The hazard ratio for all of these PFS has been between 0.5 and 0.6. So basically doubling the median PFS time. So we get double as long median PFS time. And the overall survival, that's also summarized quite boringly, except the Paloma 2 trial, which was a negative trial, and the Paloma 3 trial. Most of these trials extend the overall survival by about a year. So there's a 12 months overall survival. Specifically, the Mona Lisa study program is very consistent. All of these trials, 12 months more median overall survival with a statistical significance. So very quickly, Mona Lisa 3, that's the study in the situation where we treat in the second line or in the endocrine resistant population. That was a positive trial for overall survival. And as you can see here, an extension by about 12 months. That's very consistent in the statistically significant trial. 12 months more median overall survival. That's quite nice. So Mona Lisa 7, that's the ribociclib in the premenopausal patients. Also about 12 months more overall survival. It's 11 months, but let's round up that we memorize this data better. Mona Lisa 2 is the study in the endocrine sensitive population. So that's a vast majority of the patients that we're treating, endocrine sensitive in the first line metastatic setting, 12 months more median overall survival. If you look at the absolute number of deaths with the respective observation time around 5 years, 6 years, we have 40 less deaths out of 333 patients. So that's 40 patients less dying out of 333 by adding the CDK4/6 inhibitor. Then Monarch 3 is in the sensitive situation, very similar to Mona Lisa 2. And that study is a warning signal for the pharmaceutical companies. Don't make the trials too small. That we don't have a statistical significance, to be fair here, is most probably the consequence of a small sample size in a 2-to-1 randomization, because the Kaplan-Meier curves separate similarly to Mona Lisa 2, and we have a 12 months difference in absolute overall survival, but formally, it's not statistically significant. And then came Paloma 2. Paloma 2, my heart aches for Paloma 2 because I arrived at UCLA laboratories around at the same time when the palbociclib arrived. So this is pretty much the cornerstone of overcoming endocrine resistance in hormone receptor positive breast cancer patients. Beautifully, it prolonged progression-free survival time with the respective hazard ratios that I just mentioned. But if you look for the overall survival, we all know the story is not statistically significant. And there was actually quite a long story around this not being significant, because when Richard Finn presented this data at ASCO in 22, everybody was puzzled. Why is this study not positive for overall survival? Everybody would have expected it. Everybody would have wanted that. So the hazard ratio that was presented was an 0.96. So that's very close to the 1. It couldn't be a real power issue, because to power that effect size for significance, you need more than 20,000 patients. So that's not the case here. So the study group, together with the sponsors of the trial, pretty much contacted every study site around the planet before the full paper was published. And they called the overall survival that was the consequence of contacting every single study site, asking them to contact every single patient that might be probably lost to follow-up. There's something that is called restored overall survival data, and that was, or recovered overall survival, apologies, recovered overall survival data. it was not many patients that were added to the equation, and a very similar hazard ratio of 0.92. So not a lot of a difference. The Kaplan-Meier curves look just about the same, very close one to another, and it's not significant. To interpret this data, we might want to include a short outlook in the adjuvant setting. There were 2 trials with the palbociclib. They both were negative, Pallas trial and Penelope B trial. Huge trials with 5,600 patients and 1,250 patients. So it's almost 7,000 patients included in the adjuvant palbociclib trials. They were all negative. Regardless of that, CDK4/6 inhibitors were rapidly included in the metastatic setting, now like 80–90% treated with a CDK4/6 inhibitor in the first-line setting. So it is the cornerstone of the endocrine treatment, regardless of the overall survival data, because that happened before the overall survival data was published. There's so many discussions and CDK4/6 inhibitors being different. We all know they're different. The side effects are different. The trials show different data. It's just very hard for us to accept the situation because we always want to see a class effect. But preclinically, witnessing the uprising of the CDK4/6 inhibitors in the preclinics and the early phase trials, there was, from the beginning, quite a substantial difference between the CDK4/6 inhibitors. And you always see these branch diagrams, what it means. Every end of a branch is a kinase in a cell, like a kinase that phosphorylates another enzyme. So classical kinase definition. And you can see here the ribociclib, has a specificity to these kinases. It's quite specific. Palbociclib is also quite specific, and abemaciclib, covers many, many more kinases. There's not a quality to that. We cannot interpret, is this good or is this bad? We just see it's different. They cover different kinases on top of CDK4, of CDK6, and the side effect profile is different. If you put them into a list, you can see there's so many kinases that are covered by palbociclib and ribociclib, much less. So there is a difference that can be looked at. Also, if you're looking at the CDK4 over CDK6 inhibition, we are recently all waiting for the atirmociclib data. It's a very specific CDK4 inhibitor, but there's also others, trials up and running in the sensitive, in the resistant settings, looking for very specific CDK4 inhibitors, not CDK6 inhibitors, because the CDK4 inhibits the cell growth. CDK6 might have a little bit more pronounced effect on the immune system, but you can see here how different the CDK4/6 inhibitors are with regard to the CDK4 over CDK6 inhibition, and also plasma concentrations are quite different if you look at the unbound drug. Nevertheless, all of these substances made it into the NCCN guidelines. The ribociclib, because of the 3 trials and the overall survival benefit, in the category A, but abemaciclib and palbociclib, category 2A. ESMO has a different scaling. There 5 and 4 is better. The higher the number, the better. NCCN, the lower the number, the better. And you can see here, the abemaciclib has a 3 in the resistant situation, and it has a 1 in the non-resistant situation. There's no overall survival benefit. Ribociclib has a 4, 4, 4. That's a substantial benefit. And palbociclib has a 2, 2, and a 4, and 4, of course, because of the missing overall survival benefit. Then ABC6, ABC7 do it similar to the ESMO magnitude of clinical benefit scales. And there you can see that's quite consistent with what ESMO has said. So I was asked to give a firework moving to the early breast cancer setting. So if a substance is such an important medication, and you can see that it will follow us, and I want to look into the future in the metastatic setting, at least for the next 10, 15 years, either as a comparator in new clinical trials or as an inclusion criteria, that this is a condition for a pre-treatment, similar to the capecitabine that was introduced somewhere more than 20 years ago. That was for a long time the comparator in most of the metastatic breast cancer trials. So moving to the early setting, if a substance works so well, there is lots of studies that are conducted Does it make sense? And one of the studies that I like a lot in that context is the NEO-MONARCH study. The data was also produced with other CDK4/6 inhibitors. You can see here, if you treat the patients neoadjuvantly with anastrozole, the combination of anastrozole and abemaciclib or abemaciclib monotherapy, you can see the reduction proliferation increases a lot from 63% Ki67 reduction in over 90% proliferation reduction. And the same is true if you're looking at cell cycle arrest. Ribociclib data in a clinical setting. This was a study all in luminal B tumors, high proliferative endocrine responsive tumors in the neoadjuvant setting. Almost all of these tumors are turned to low proliferative luminal A tumors. So very, very good efficacy, using the ribociclib in the early breast cancer setting. And that puts us to a situation where I am a little bit proud, but also a little bit sad to help to conduct and to design specifically the NATALEE trial, because during that process, I realized that 20 years after the discovery of the molecular portraits of breast cancer, that's in the year 2000, and the hope was high that we could use expression profiles now being used as multi-gene expression assays to predict responsiveness to chemotherapy and responsiveness to endocrine therapy. But all of that failed. They're prognostic tools, but we were not able to identify them as predictive tools for chemotherapy response or endocrine treatment response. So almost 20 years later, we're there designing the next large-scale adjuvant hormone receptor positive trials, and we're still stuck with the same idea. Patients who have a very good prognosis might not need additional treatment, and patients with a bad prognosis, these are the ones with a high medical need where we possibly want to escalate the therapy and give more. We're not in a position to stratify the patients according to a molecular test, saying, okay, these are the ones who are endocrine resistant. We're not able to do that despite all the genomic data that was generated over the last 25 years. And we are world champions in the medical field for predicting prognosis. I'm talking to neurologists for stroke. I'm talking to cardiologists for heart attack. They do not have these advanced models to predict prognosis. Only tumor size and nodal status are very good already to do it. Ki67, you might like it or not. With a high cutoff, it pretty much defines a good, has a good stratification power to identify patients with a decreased prognosis. Tumor grading is, I think, undisputed. And again, multi-gene assays, you might like them, you might not like them, you might have easy access to them or not, but they're very good prognostic tools. The second thing that immediately comes to your mind is the recurrence risk over time. We're giving endocrine treatment 7 to 8 years. And we all know these trials. 2 years were better than 1 year, 5 better than 2 to 3 years, 10 better than 5 years. And then it was too much. And to emphasize how important it is to cover the recurrence risk, I want to attract the attention to the middle graph. That's the recurrence risk over time, And these patients are patients treated in the end of the 1990s, where not all hormone receptor positive patients were treated with endocrine treatment. So these are patients not treated with endocrine treatment. And you can see here that what we usually see in triple negatives is also true for hormone receptor positives without endocrine treatment. Very aggressive recurrence pattern in the first 5 years. On the left side, these are mainly triple negatives. That's what's still the case today. But if we treat these patients with endocrine treatment, we get this recurrence risk over time over here. And regardless of any escalation with CDK4/6 inhibitors, I think it's very important we keep the patients on the endocrine treatment as one of our main jobs when we talk to the patients and when we are seeing our patients in the first few years after the diagnosis. But yet, if there would be something to improve the treatment here in the first 5 years would still be a good thing. So first, keep the patients on the treatment, super important, because the disease is super aggressive if not treated with an endocrine treatment. If you have something better, even better. And the Monarch E study is one of the studies that was positive in that context, focusing on high risk, 4 lymph nodes or more, or 1 to 3 lymph nodes with additional risk factors. Of course, there's a very high recurrence rate in here. Endocrine treatment was a comparator arm, and then 2 years of abemaciclib were added. This was rewarded with a hazard ratio of 0.73 for invasive disease-free survival and about 6.5% absolute difference after 5, 6, and 7 years of follow-up. So it's a 6% absolute difference. Last year at ESMO, we saw the overall survival data. Looks very different from lidERA. These Kaplan-Meier curves separate very late. So my opinion, in the metastatic setting, we kind of control for death for a few years before patients start dying. And so we see the Kaplan-Meier curves to split apart after 4 years, up to an absolute difference of 1.8%, hazard ratio 0.84, p-value 0.027, which is formally statistically significant. After 10 years, I'm not going to go into detail for the side effects. The other trial is the NATALIE trial. NATALIE trial I had the joy and pleasure to help designing and conducting. The most recent follow-up is the 5-year outcome. The abstract for the 6-year outcome was just submitted to ESMO this year. Nobody knows the data yet. Nobody, I promise you, nobody knows the data yet. But of course, everybody is hoping for more stable signals for the overall survival. Here, all node-positive patients were allowed, and if node-negative, additional risk factors were needed, like a large tumor, 5 centimeters or larger, or if the tumor would be 2 to 5 centimeters, grading of 3, or a Ki-67 of 20%, or a high genomic risk profile combined with a grading of 2. So high-risk node-negatives, treatment ribociclib 400 milligrams for 3 years, lower dose to save on the side effects. So 400 milligrams have less side effects, and 3 years to maybe cover 1 more year of this increased recurrence risk after the early disease diagnosis. As for the IDFS, we see a 4.5 difference. The risk profile, of course, is a little bit lower than in Monarch E. It's still high-risk patients, but it's a little bit lower. So the absolute difference here is a little bit less, but the hazard ratio is very similar, 0.71, maybe even a little bit lower. Everybody wants to look into the future, so we're looking at these compiled bar graphs for distant metastasis, because almost all patients will die of metastasis. You can see here that there's a quite profound reduction in distant metastasis by adding the ribociclib. There's no subgroup that's really sticking out, except maybe the node-negative. So patients with a lower risk of recurrence, still increased risk of recurrence, but these absolute difference give some countries a little bit of a headache. In the Nordic countries like Sweden, or is it Norway? I forgot, Norway or Sweden, they want to exclude lower risk patients from that treatment and said, okay, let's include some of the lowest node-negative patients. But now you can see an absolute difference of 5.7%, hazard ratio 0.60. That's numerically lower than the 4.4% in the node positives. So now if you want to prevent recurrences in your population, you have to treat less patients, number needed to treat, that are node negative, less patients to prevent recurrences than node positive patients. So this approach with the highest medical need and excluding patients with a lower risk doesn't really work out with these stratified analysis of a large benefit in the high-risk node negative patient population. Distant disease-free survival, distant recurrence-free survival is all consistent with the primary study aim, and the overall survival, I just mentioned it. The 6-year follow-up is submitted to ESMO. Nobody knows the data yet, but for now, last year data, 1.6 absolute difference after 5 years, hazard ratio 0.80, and you can see here, this is a little bit more than 200, or it's exactly like, 300 events compared after 5 years, compared to the 7 years of Monarch E, that's 600 events. And so there's more events needed, to make this analysis a little bit more stable. So hopefully not many patients died, but on the other hand, these events will make the difference for a stable overall survival analysis. Because the difference over time, this is the interim analysis 2, that's the 4-year analysis, that's the 5-year analysis, and that's the difference between patients who are dead, this is blue, and patients who are alive with metastatic disease. That difference keeps on growing over time. So at this time point, there's no real reason to believe that just by waiting, the overall survival will not become positive at some time point. So let's hope for that, because it would be a good message for the patients to have both substances that obviously at first sight have a similar efficacy, that both substances fulfill a overall survival benefit. Again, after 10 years, I will not talk about the side effects anymore. I'm sure you have all the respective experience. What do the guidelines say? The ESMO has put a score of A, that's the highest score for both substances, the ribociclib and the abemaciclib. The NCCN guidelines mention the respective substances in a category 1 way in the respective situations where the respective risk profile is met. The last 2 minutes is always about how necessary is this therapy, because we're always talking about that. And this data, and there's a caveat, so I want to be cautious here. I want to believe in the Middle East, the situation is a little bit more different. There's more younger people. There's more patients with stage 2 and stage 3 disease compared to a westernized population-based mammography screening population. But in that population, I think it's still good enough to look at the Monarch E population. The NATALEE is almost 3 times as big as the Monarch E population. But in these westernized populations, NATALEE, 70% of patients have a lower recurrence risk. So that's the 30% highest recurrence risk, and 70% of the patients are left alone. And it's also nice to see that the 2 curves here, the violet one is low risk node positives, and the blue one here is high risk node negative. So it was really possible to select these high risk node negative patients. To be efficient, we have to be aware of the discontinuations, 40% even without the CDK4/6 inhibitor. The oral therapies are discontinued just at 20%. 20% Monarch E after 2 years, 20% NATALEE after 3 years. And also as a comparison, Olympia, it's also about 20% olaparib discontinuations after 1 year. And it makes sense. The patients are by themselves. I have to admit, I once had to take a beta blocker, and I didn't take it for some time because I didn't like it. So compliance, adherence, persistence is something that not only has to do with side effects, but also with character. And if you have side effects, it becomes more and more difficult. 2 weeks ago at ESMO Breast, the 5-year follow-up data of NATALEE was just presented, similar to Monarch E. We don't see a difference for general health score, physical functioning, fatigue, nausea, vomiting, diarrhea, pain, breast symptoms, sexual functioning. And if you look at deterioration of quality of life over time, no difference. But please be aware, quality of life deteriorates when we start the endocrine treatment. There's no question. The patients have side effects, musculoskeletal symptoms, sleep disorder, other AEs, and that's not prognosis, that time to discontinuation. If they have pain in the first 30 days, they're more likely to stop the treatment. The last hint is, at our center, we introduced the MOATT checklist. It's a standardized checklist to talk to the patients, was published in JCO. And if you are distributing that checklist to the nurses, to the doctors, to the pharmacists that speak with the patients about the respective oral tumor therapies, then they ask the patients the question, did you understand what I just told you? And the patients have to proactively reproduce what they were just being told. There is a difference in discontinuation, hospitalization, and even death in this prospectively randomized trial. And they're really trivial. How does the tablet look like? That's in German, apologies. What's the doses? How many times do you have to take it before or after the meal? What are the side effects? What are the phone numbers I need to call if something happens? How does it need to be stored? And then there's room, that the patients can respond to the question, what did I just tell you? I think, Shaheenah, I'm just a few seconds ahead of time, but I was asked for a firework before your firework, and I'm all focused to listen to your cases and see, what are you challenging us with? I'm sure there's lots to talk about because endocrine resistant treatment has developed so rapidly over the last 20 years.
No, thank you very much. I want everyone's videos on. We'll have a rapid fire with the cases, and I'm sure everyone has questions for you, Peter. But let me just bring up the slides, and I'll just share them. We will start off with early stage breast cancer. I think, as we start to incorporate CDK4/6 inhibitors into the adjuvant setting, Peter, I need to ask, have you actually seen in your clinical practice anyone relapse while on a CDK4/6 inhibitor in that early stage setting?
Oh, yes, we do. We've seen that. I mean, we shouldn't forget these are high-risk patients, and
Of
the recurrence
course.
rate over 5 years is still about 10%, and it's quite equally distributed over time. So it's 1 in 25 patients, 1 in 50 patients we put on the treatment who relapse in the first 2 and the first 3 years. And we are putting a patient on ribociclib. During COVID, we've put many patients on abemaciclib, and we have like 2 patients per week. So it's a large early breast cancer treatment center. And, and then you see there's patients that will recur eventually.
Okay, let's go into the first case. This is a 40-year-old woman. She's premenopausal, typically what we tend to see here in our part of the world. She has stage 2B disease, 2 clinically positive lymph nodes, grade 2, 4-centimeter tumor. Ki-67 is 35%, and she has an oncotype score of 27. So this is a T2N1 disease. Maha, in a 40-year-old woman, would you do an oncotype mutation with a T2N1 disease, premenopausal, Ki-67 of 35%? Would you actually do an oncotype over here?
Yeah, so we don't do for premenopausal women in our institution who are node positive. And certainly she has, it's a sort of a biggish tumor, high Ki-67. So I think there is definitely more than one factor here. So no, generally, I personally don't think that this patient need oncotype because as for the data that we have, can you really say that remission of chemotherapy here,
So
is,
let me change the question a little bit.
Mhm.
Dr. Tarkan, if this patient's oncotype had come out to be 24, would you give chemotherapy to this patient, 40-year-old, 2 clinically positive lymph nodes, grade 2 disease, 4-centimeter with a Ki-67 of 35%?
24, yes.
You would give chemotherapy. Peter, does this patient actually require oncotype in your mind, irrespective of what the oncotype score comes back? This is a young premenopausal woman, high Ki-67, and 2 lymph nodes positive. Should we not give chemotherapy is the question.
Well, everybody wants to be brave and everybody wants to not give chemotherapy. But I guess in that case, most people would feel quite uncomfortable not to give a chemotherapy. So I would offer this patient a chemotherapy. Maybe not. Yeah.
I'm sorry I'm interrupting you, Peter, but you come from Germany. And I want to ask, do you do the ADAPT protocol that Nadia created and has presented several times of giving neoadjuvant endocrine therapy and then assessing to see if the patient actually requires chemo and looking at that Ki-67?
Yeah. Well, most study sites do that. We're not part of that network. So, and also if you look at these trials, the number of patients who are premenopausal, and then you look at the stratified subgroups to draw conclusions is very small. So I'm not sure the ADAPT trials provide us a lot of information for this young patient population. And even you might remember, if it's like you're from Germany, so like what pops up in my mind is much more the development of the dose-dense chemotherapy regimes some time ago. So I would guess this woman would have been offered a dose-dense chemotherapy in most of the study sites. I might be a little bit more forgiving and discuss with her a possible TC chemotherapy. But the oncotype is 27. If you look at the anthracycline subgroup analysis, she might even benefit from some anthracycline-containing chemotherapy a little bit more than from a TC scheme.
Okay, Dr. Tarkan, what would you give this patient? You have several choices here, chemo followed by endocrine therapy, or would you add a CDK4/6 inhibitor? Would it be a BEMA or ribo? Or would you be brave enough to just give her a BEMA plus endocrine therapy or ribo plus endocrine therapy? Dr. Tarkan, very quickly, this is
Yeah.
fireside.
Okay, sorry. I will give chemo. My question is to Peter. 27, you will use anthracycline or you will take the cutoff 31? You will answer later for me. I will add CDK4 plus AI and plus
Dr.
OFS.
Tarkan, which CDK4/6 inhibitor would you give this patient? KIC7 is 35% grade 2 T2N1. She fits into the criteria of cohort 2, actually, of monarchy.
Two, yeah.
So would you give
Ribo.
a BEMA or ribociclib? Just tell me
Ribo.
which you'd give ribociclib. Sinem, what would you give? A BEMA or ribociclib? You're muted, Sinem.
Sorry, ribo.
You'd give ribo. I'm seeing a lot of ribos over here. Peter,
Ribo
or
and no anthracyclines.
ribo and no anthracyclines. All
Tarkan
right.
asked that question, not you, Shaheenah. Tarkan asked that
Okay.
question.
No anthracyclines. I actually, that data that came out from San Antonio, the retrospective analysis that looked at anthracyclines and the cutoff, I'm actually not so sure that we should all be following that. I think patients' treatment strategies need to be individualized. I still have my doubts in that retrospective study, but that's a conversation for another day. And just looking at the Natalie's full population, the Monarch E population, you can see in this patient with 1 to 2 she's got 2 lymph nodes positive, so it would be in this category of patients. And the tumor size, you can see that a BEMA is given in those patients with more than a 5 centimeter tumor. But here less than 2 or more than 2 and less than 5 is actually only ribo. But the patient would also fit in cohort 2 very quickly, Peter. Should we be using cohort 2 strategy? I think it's a Ki67 of more than 20% that has triggered the question of whether or not we should use a BEMA in this patient.
I mean, the abemaciclib works independent from the Ki67. There was a quite dedicated subgroup analysis, and therefore it can be used. It must not be used. I mean, we have the ribociclib, which is eligible for all of the patients. Every patient is covered in the end. I think it's more an academic question whether to specifically make. So, no, I don't believe Ki67 is the deciding factor for or against the abemaciclib. It works high and low.
Okay, Maha, very quickly, and I need just a one-word answer. Say, suppose this patient, premenopausal, 40 years old, actually has 4 lymph nodes that are positive. Are you going to give BEMA or ribo, considering we've seen that overall survival data, strong 10 in Natalie, positive in BEMA in Monarch E, simply because it's longer follow-up? What are you going to give, a BEMA or ribociclib?
I think it can be either treatment. I don't think I'd have I'd discuss with the patient what are her preferences. Once a day, 3 weeks on, 1 week off, toxicity. I'm happy with both treatment.
Okay, Ozge,
Yes,
what would you give, a BEMA or ribociclib?
I think I would go with ribociclib.
Why?
And either options are valuable, I think, but like from the personal experience with the compliance and the toxicity and such, they are more compliant with the ribociclib, but I observe that's why.
Okay, Peter, what would you give in this patient and why?
What's the options? I mean, this
patient now has 4 lymph nodes that are positive instead of 2. So Monarch E or Natalie.
Most probably she would get a dose-dense chemotherapy and
Of course.
containing anthracyclines and the ribociclib.
Ribociclib, but why not a BEMA here?
Oh, it depends. I'm not suggesting this for anybody else. It just fits our setting much better because of the side effect profile. I just don't like the patients to stop the treatment home alone when they get the diarrhea. They might not contact us. They're not close by.
Okay,
All the decisions with
reasonable.
ribociclib are done by us. But as for efficacy, I think everybody would agree there's not a lot of difference between the two medications, as far as it goes for efficacy.
Dr. Tarkan, what if this patient had a BRCA mutation? What would you start off with after giving the chemotherapy to this patient? What would you give first?
I will give olaparib, and then I will
Okay.
continue with ribociclib, because we know from the data they included the patient.
I think very, very reasonable. That's exactly what I would do. But Peter, we actually don't have data in this realm. My question to you is, do we need to use a CDK4/6 inhibitor post that 1 year of olaparib? Because if you see the Olympia data, these patients actually had a very early overall survival advantage. Do we need to extend it and give that 2 years or 3 years of ribociclib after the olaparib?
I don't know, but these patients have a high risk of recurrence, and if there's no financial constraints, I think everybody would feel a little bit more comfortable to at least try the treatment. Let's not forget not the vast, but the larger part, the majority of women do not have these side effects we always talk about. So I think it's always advisable to offer this treatment, to start this treatment. And if you have any doubt that there's good enough data or whether it's really necessary, you can then be a little bit more forgiving if side effects occur, and you want to stop the treatment because of the side effects. You can do this a little bit more rapidly, I guess,
So
in that
next
situation.
Next question, Peter. This patient receives 1 year of olaparib. Are you going to give 3 years of ribo or 2 years of ribo?
3 years of ribo.
3 years of ribo. All right. So I think we've already answered this question. We're looking at Natalie and the efficacy by prior endocrine therapy. It looks like irrespective of whether you receive, when you started the endocrine therapy, because if I'm not mistaken, Natalie allowed you to stay on endocrine therapy for quite some time before you actually had to use ribociclib. And these patients actually did very, very well. So, Peter, I need to ask you a very practical question. Natalie allowed you to be on endocrine therapy for up to a year prior to actually starting ribociclib, allowing a whole range of patients to actually be included in this cohort. But what is the ideal time to actually start? Because my fear is in the community, people will say, okay, let's wait 6 months, let's wait 12 months before we actually give the adjuvant CDK4/6 inhibitor.
Well, that's why I've shown the hazard functions over time. I would start as early as possible. But if a patient comes and hasn't started yet, this gives us the opportunity to start it later. If I haven't started it, but it should be our mission to start every patient as early as possible.
Okay. Now, what if this patient had started abemaciclib? So, Maha, this is for you. What if this patient had started abemaciclib and couldn't tolerate the GI side effects that Peter has been talking about? Would you consider switching to ribociclib?
Yeah, certainly.
That would be an easy switch. But I'm
Mhm.
actually curious, Peter, if I may ask you that question, because we're going to go into the node negative realm. I recently had a patient, node negative, with an oncotype of 40. So really high risk, premenopausal. She's in her 40s. Oncotype was very high. We started her on ribociclib in the adjuvant setting. She actually was perfect criteria for Natalie to start. Impossible to give her the ribociclib because she had significant neutropenia. Like I could never get her ANC to go above 0.5. It was like horrible. And she was also getting significant migraines. At that point, my question is, could I reasonably go from ribo to abemaciclib in that case? She's node negative. She doesn't fit the criteria for Monarch E.
I would do it. I mean, it's a question of payment in Europe, but I mean, if the insurance company allows that and we have made good experience with that, of course. I mean, that's what I mean with it's good if more than one substance is available for us doctors because we want to have some flexibility to keep the patients on the treatment. Yeah, I would switch.
Okay, let's go to the next question. This is a 58-year-old postmenopausal lady, stage 2A breast cancer, node negative disease. It's grade 3, 4 centimeter tumor. Ki-67 is 30%, and Oncotype DX is actually not available for this particular patient. Dr. Tarkan, would you give this patient chemotherapy or would you give this patient CDK4/6 plus endocrine therapy? You do not have information available on that oncotype.
So this is the critical point. If I give chemotherapy, how much benefit is this one? We have the data, it is, 2%, 5%, but I will discuss with her, but ribociclib eventually she will receive.
So, Peter, this is the reason why we brought this case up, because we frequently find patients where they're unable to afford oncotype and insurance refuses to cover it, yet it'll cover everything else. So this is a very typical patient that we will actually see here in the UAE where we can't do an oncotype. Now, in Natalie, the majority of those patients actually had chemotherapy. And patient has a grade 3 tumor with a high Ki-67. Would you or would you not give chemotherapy? She fits Natalie to get ribociclib, but the question here is, would you in addition give chemotherapy?
How large was the tumor again? I mean, it's like 2 and 5 centimeters is a difference, in my
It's a
opinion.
4 centimeter tumor.
So quite reasonably sized tumor. She has a high Ki-67, so most probably we would offer her 4 cycles of TC in that case. But there are some doctors that are brave enough to leave it out. I wouldn't. I would still recommend 4 cycles at least of TC if the oncotype is not available. But that's a classical case where the oncotype might actually help us to make a decision. However, the grading is 3, the Ki-67 is 30%. The likelihood that this oncotype is somewhere at 15 or 16 is pretty low.
So actually, Peter, I had a similar patient recently where she came to me for a second opinion. I did an oncotype. It was a grade 3 tumor. It was also T2 and 0. She was also postmenopausal. Ki-67 was actually 35% in that particular patient. I did an oncotype and it came out to be 22. So do you give ribociclib to such a patient?
Yes, I
Okay.
would offer it because
Because she
we can.
fits the criteria, still grade 3 tumor. She fits the
Yeah.
criteria. So my point is, you don't only rely on the oncotype, you have to look at all the phenotypic features. So that's the question that came up. What if this patient had an oncotype
Yeah.
of 20? Would you give adjuvant ribociclib? I
And
think Dr.
and
Tarkan
Shaheenah,
would give. Yes.
Shaheenah, sorry to steal a little bit of your time, but it's my heartfelt desire to tell you that the
Yeah.
Natalie trial wanted to be nice to the doctors. It's
Okay.
not an academic discussion. It's not what you have to do or what you must do.
Yeah.
You can use the inclusion criteria to put a patient on the ribociclib. If you want to
Okay.
use the Ki-67, do that. If you want to do the oncotype, do that. If you don't want to use that, don't use it. But it should give you the flexibility to do whatever you think is appropriate.
Absolutely. Thank you for designing the trial like that, Peter. I'm sure Ozge, Tarkan, Maha, and Sinem are all happy that you gave us the flexibility to do that in our clinic. Next case, this is a 42-year-old premenopausal woman, 2 lymph nodes that are positive, grade 2, 4 centimeter tumor. Ki-67 is 30%. She gets adjuvant chemotherapy as well as adjuvant radiation therapy. Sinem, would you give a CDK4/6 inhibitor to this patient?
Yes, absolutely.
And what would
I
you
would
give?
favor. Yeah.
What
Yani
would you give?
ribociclib mostly because of the side effects and efficacy. Yeah.
Peter, would it be wrong to give a abemaciclib here?
It's an N1 tumor, grade 2, Ki-67. Yeah, I mean, she has 2 lymph nodes. She would need a grading of 3 or tumor large of 5 centimeters.
Okay.
But
Dr.
the
Tarkan,
grade, yeah, the indication grade 2, I will go with ribo.
you would go with
Because of the
ribociclib.
She would be in cohort 2, but that's not approved, It's
Yes. Yes. Okay. Well, at least we got that sorted out. Now we shift over to metastatic breast cancer. I think the adjuvant is actually more interesting, and I think what's going to happen in the metastatic.
Shaheenah, can I ask a question?
Yes,
Can I
please
ask?
go
Well, I
ahead,
have
Dr. Tarkan. You're
Peter.
my friend. You can ask anything you want.
Thank you. Peter, we have now in San Antonio and also now in the ESMO breast some data that if the patient received neoadjuvant treatment, please check also the post-surgery residual disease because there is a shifting from luminal B to luminal A. Now we are getting more data about that. Will you use that in your practice?
I'm a very bad person to ask because I have a very strong personal opinion about neoadjuvant chemotherapy and hormone receptor positives, I avoid it wherever possible. I avoid it wherever possible. If you look at the Monarch E data that was presented at ESMO, the patients who don't go down with the Ki67 have a prognosis so bad that's not only explainable by the pre-therapy Ki67. So I'm always a little bit concerned that exposing a tumor where the majority is not responsive to the treatment develops some kind of escape strategies that make this tumor worse than it was before. And there's other data that might support that. So I'm like not a good person to ask because I have a so strong opinion. Guidelines say neoadjuvant therapy is as safe as adjuvant therapy, so everybody can do that. Everybody can, like adapt that or do the adapt scheme or whatever they want to do. I personally avoid any kind of neoadjuvant chemotherapy and hormone receptor positive because of that.
All right. I slightly disagree with Peter over there. I have
That's
patients
fine.
where I have given you adjuvant. Today I had a patient with hormone receptor positive, HER2 negative disease who has a Ki67 of 70% with big lymph nodes in her axilla. And my surgeon is like, please give neoadjuvant. I need to downgrade this tumor. But that's just from a surgical perspective. Okay, let's shift over to the metastatic breast cancer realm. We have two cases. This is a 46-year-old marketing manager, hormone receptor positive, HER2 negative breast cancer she was diagnosed with, which has relapsed. She completed treatment for early breast cancer 5 years ago. She's postmenopausal and she's eligible for an AI. She's got grade 3 disease. Her metastatic disease includes the liver, bone, and lung. She's got abnormal liver function tests, which suggests to me that she's at that tipping point of getting into visceral crisis, most likely just a little bit before she tips over completely. And of course, her tumor markers CA15-3 is elevated. Profiling of the tumor does not show any specific mutations, including a PIK3CA mutation. Dr. Maha, would you consider this patient to be in visceral crisis, or do you need the results of the liver function to determine whether she's in visceral crisis or not?
Yeah, I think we need to know the results, right? The bilirubin at least.
Does it
Yeah.
matter? Does it matter if, the liver function is slightly higher or just at the tipping point? What would you give this patient?
I think it would. I mean, if it's only the AST and ALT and it's one time upper the limit, I'm happy to start. But if it's the bilirubin is high and it's the ALT and AST are, 3 times or 4 times the upper normal limit, I probably wouldn't be so comfortable going in with, oral
CDK4,
treatment.
yeah.
And clinically, she looks well.
Yeah, clinically she looks
Even
fantastic,
if it's
except that picture is not
they all
hers.
clinically look
That
well.
picture is not hers, I can tell you that.
know?
But Peter, I need to ask you this question since you're the expert, and we saw the results of the Right Choice trial that told us that we could use CDK4/6 inhibitor in the form of ribociclib and endocrine therapy in these really high risk group of patients that are not technically in visceral crisis, because I read the criteria for that. So tell me when you would not give a CDK4/6 inhibitor if a patient is in visceral crisis, because in my mind, visceral crisis is a spectrum. At one end of the spectrum, the liver function is distorted, but the patient is not deeply jaundiced. And I've taken those patients out of that visceral crisis point and given them a CDK4/6. But then I've had patients where they're deep yellow and they look like they're heading towards the ICU. I give them chemotherapy. What are your thoughts here?
Well, first, I don't consider myself more an expert than the colleagues here on this call, but my personal opinion is I would start this patient on CDK4/6 inhibitor and endocrine treatment. I would not give, but as you said, it's a spectrum of emotions and motivations.
Yes.
I personally would see if I actually do see a organ function deterioration, and with the liver, I want to see a high bilirubin, for accepting that the liver is under danger. A quite high LDH is also a good indication for imminent organ failure, where we want to see a more rapid response. And it's not much more rapid, but it's a little bit more rapid, I think, with the chemotherapy. But this percentage has gone down to somewhere around 10% or 5% where we want to start with the chemotherapy in the first line setting. But this patient definitely doesn't sound like it.
Yeah, no, for sure not. I was just asking about the different spectrums that we consider CDK4/6. So, Peter, let me ask you this. You can give anything you want. There's no regulatory approval. There's no cost prohibition. Which CDK4/6 inhibitor would you use for this specific patient in this case?
I would try the ribociclib. I mean, it's a consistent highest efficacy. We have the right choice trial that shows us there's a benefit over the chemotherapy. That's the safest, standpoint as far as efficacy goes. Of course, you squeezed in the abnormal LFTs here, so we have to watch them and see what happens very closely. But I would start with the ribociclib.
Ozge, what are your thoughts here? Which CDK4/6 inhibitor would you start with?
I will definitely agree with Dr. Peter, and I will go for ribociclib.
Okay, let's go on to the next case. This is a 24-year-old lady, and she was diagnosed with hormone receptor positive, HER2 negative advanced breast cancer 15 months after stopping her adjuvant therapy. She's got an ECOG performance status of 1, invasive adenocarcinoma is biopsy proven, grade 3, but she has a PIK3CA mutation disease. CT confirms metastases in the lung and in the liver. So, Maha, would you consider inavolisib for this patient? Maha?
Yeah, I'm listening. Again, it's a difficult question. I want to recall if it was more than 12 months, I think, right? Was it more than less than 12 months from
It's
in the
15
trial?
months. That's
15
why I put
months.
it in
So
there. Otherwise, why would I put it in there? I had to make it
it is.
difficult. Okay, let's hold
Yeah.
your thought there. Let's hold your thought there. Peter, 15 months after stopping adjuvant therapy, would you do Inavo over here? 15 months, PIK3CA mutation. This lady is 24 years old.
Yeah, yani,
Yes.
wallahi.
I,
I will give
I,
whatever I have.
Well, the thing is, now we're combining, and we see the data from the Monarch 3 and Mona Lisa 2 for the PI3 kinase mutated for the overall survival. And of course, it's cross-trial comparison, but it looks quite similar. So the question is, are we ready to give a triple regime with a less efficacious CDK4/6 inhibitor to see a benefit over a non-standard treatment that we would give and accepting all the side effects, or would we go with standard treatment? I would go with a standard treatment and then second line go for the capivasertib. I would give her just a CDK4/6 inhibitor and endocrine treatment, and then second line go for the for the inhibition of the PI3 kinase pathway.
So, I mean, I tend to agree with you, Peter, but I also think that Capitella 291, which is, the capi plus fulvestrant regimen for patients, maybe, and I asked you this question yesterday, Peter, in terms of sequencing, you may get the same outcome like giving triplet therapy in the beginning because Inavo 120 did not have a sequencing component to it. What are your thoughts here?
I'm not sure I understand the question. For me, is quality of life is in
Yeah.
the focus here, and there's a good chance that we are achieving the same overall survival with a longer period on a more tolerable treatment with a CDK4/6
That's
inhibitor
what I'm trying to say. That's what I'm
and
Yeah,
trying to say.
yeah.
and the letrozole, and then second line, the period under which the patient is, let's say we're lucky and there's a longer response with the inavolisib, but there could also be a long response with the ribociclib, which is much more tolerable than the triple therapy. And then second line, the capivasertib, I like a little bit better than the inavolisib as far as it goes for therapy management. So
Side
it's
effect
it's weighing quality of life and the response time under which treatment. That's my reason for sequencing it this way and the other, not the other way around.
So, Sinem, Peter has told you can't use Inavo because it's 15 months and he wants to sequence therapy. So, what are you going to use first line therapy in terms of which CDK4/6 inhibitor and which endocrine therapy are you going to use? Remember, she stopped her endocrine therapy 15 months ago. So, what are you going to use? I just need the combination.
Yeah, I will choose ribociclib plus and AI plus and goserelin or any
Okay,
LH.
perfect. Perfect. Tarkan, what would you give over here?
I agree with Sinem. My question will be, did she use in the adjuvant setting AI or
She did.
tamoxifen?
She used AI, but
Which
it's
one?
15
AI.
minutes after stopping adjuvant therapy.
Yeah. And a fulvestrant ribo, I can also combine, depends on my.
So Peter,
But
what
in the second line, we will use fulvestrant. That's why I will stay also in AI.
AI? So Peter, 15 months after stopping 5 years of AI plus ovarian function suppression, what are you going to give in terms of the endocrine therapy partner with ribociclib for this particular patient?
Letrozole. I mean, she's
Okay.
endocrine, she's standard definition of endocrine sensitive.
Definitely. But I will include this patient in Serena 6 almost. I will check that because she will have soon something. What do you think?
I think
We,
that is perfect ending to this symposium, telling us we are innovative and we will push on into the next generation of precision oncology by testing for ESR1 mutation all the way through that ribociclib AI combination. So we've reached 9 p.m. Dubai time, 8 p.m. I think your time in Bahrain. And I don't know what time it is at your end, Peter, but I know you have to get going for your next meeting. Thank you all for being such a sport. This has been such an interesting conversation in terms of the fireside chat. And of course, Peter, your lecture was freaking awesome. So I hope to see you all at ASCO in a week or two, and Eid Mubarak to everyone for next week's holidays. I hope to see you at the next edition of the EIOC Journal Club. So thank you very much. Take care.
Thank you.
Bye.
Bye-bye.
Bye-bye.
Bye.
thanks, Shaheenah. That was great. Bye-bye.
Thank you.